एडमिट करें ऑल
हमको कर दो यार, वो सोचा करो, वो कर दिया करो, पेमेंट में लगा दो।
सर अभी डॉक्टर संजय सर नहीं आए,
वो आ जाएंगे। सबको पढ़ने के लिए
गुड मॉर्निंग डॉक्टर संजय।
गुड मॉर्निंग।
आपका नाम आ रहा है डॉक्टर सिद्धार्थ दत्ता, आप आई थिंक रीनेम कर लें। जो ऊपर डॉट्स है ना, उसको प्रेस करके रीनेम कर लेंगे।
और चेतन कैसे हो?
बस बढ़िया, सर्दी बहुत बना रखी है आपने लखनऊ में। एंड सुना है कि 4.5 डिग्री टेम्परेचर था कल। अभी रहेगा एक हफ्ते, शिमला से भी ज्यादा ठंडा है।
और अभी तो बारिश हो रही थी।
सही कह रहे हैं।
ठीक है, नाउ इट्स ओके चेतन।
यस इट्स ओके। आपकी स्क्रीन शेयर एक बार देखिए क्या हो रहा है। अच्छा मेरा खुद का नाम गलत है, मैं खुद का नाम सही कर।
ठीक है, कैन यू हियर मी नाउ?
यस यस वी कैन हियर यू। आपका एक बार स्क्रीन शेयर भी कर ले, देख ले कि हो रहा है नहीं हो रहा।
ठीक है।
यस सर।
ओके, ये करते हैं। It is okay. Dr. Chetan.
Dr. Sanjay, so are we good to go?
Yeah.
Right. Right. Dr. Sanjay is professor and head, Department of Periodontology, Career Postgraduate Institute of Dental and Medical Sciences. 1 second. If I speak about Dr. Sanjay, so Dr. Sanjay did his graduation from the Institute of Dental Sciences, Patna, and post-graduation in periodontics from the College of Dental Sciences, Davangere, and is my super senior. Sir, can we keep the rest mics on mute, sir? He has more than 18 years of clinical and academic experience and has more than 50 publications in repute in national and international journals. He has a special interest in dental implant and regenerative procedures and all procedures, and has put extra efforts in achieving achieving these various treatment modalities. So today, Dr. Sanjay will be covering periodontal microsurgery, a progressive evolution. So we are very excited to listen to your lecture. So please, welcome, warm welcome.
Thank you, Dr. Chetan, for your nice introduction. Firstly, I congratulate Dr. Vivek Benz for conducting this program. From last 3 months, he is conducting this program. He's taking so much of pain and making me part of this program. Thank you, Dr. Vivek. And so today the topic of my lecture is periodontal microsurgery, a progressive evolution. In this, I will cover the introduction part, the principles of microsurgery, the ergonomics in microsurgery, the concept of microsurgery, and the applications of microsurgery, and lastly, the closing, that is the future perspectives. So coming to the periodontal microsurgery, dental sciences have involved through a lot of changes in its concept and techniques. The aim of the surgical therapy is not just survival of a patient or an organ, but also to restore its function and to improve patient comfort. These demands are mostly met through minimal invasive surgical approach. This leads to the entry of microscope into dental practice, which leads to the era of the greatest advances in modern dentistry. The periodontal microsurgery is one of the promising advancements in the field of surgical periodontal therapy. Microsurgery is broadly termed, is defined as surgery performed under magnification by microscope that was given in, by Daniel in 1979. According to Serafin in 1980, microsurgery is a modification and refinement of existing surgical techniques using magnification to improve visualization with application to all specialties. Microsurgery is the best option available when little damage to the tissue and healing by primary intention are required, rather than relying on surgical areas to granulate in and heal by secondary intention. Hence, microsurgery in periodontology can be applied for all the procedures ranging from perioplastic surgeries to regenerative procedures and implant dentistry. Now, the thing comes is, what is periodontal microsurgery? Periodontal microsurgery is the refinement of basic surgical techniques made possible by improvement in visual acuity gained by the use of surgical microscope. This was given by Tibet in 1998. Now coming to the background, that is the history. In 1921, Carl Nile, the father of microsurgery, first used a binocular microscope for the treatment of deafness for ear surgery. In 1960, microsurgery was standard in many specialties such as neurology and ophthalmology. In 1978, Apthekar and Jaco first introduced microscope to the dentistry. And in 1986, microsurgery has been practiced in endodontics. In 1992, microsurgery was introduced to the field of periodontics, and in 1993, Chanelak and Tibet conducted a CD on microsurgery at the annual meeting of American Academy of Periodontology. And in 2002, AMED is formed, the Academy of Microscope Enhanced Dentistry. Now coming to the principles of microsurgery. What are the various principles which you should follow for microsurgery? Microsurgery incorporates three important principles. First is that it enhances motor skill, which is accomplished through improved visual acuity and the use of a precise hand grip. Minimal tissue trauma, which is accomplished through smaller incisions, and primary passive wound closure, which is accomplished by microsuturing. Now coming to the ergonomics in microsurgery, various postural and ergonomics ways of reducing unwanted hand movements with the use of surgical microscope result in more precise surgeries and greatly reduce surgical fatigue and development of spinal and occupational pathology. To overcome this, the operator must be in relaxed with comfortable body posture, supported hand, and a stable hold on instrument. Now coming to the hand control, during microsurgery, physiologic tremors, which is the uncontrolled movement arising from both the intended and the unintended actions of our body, manifest as a naturally occurring unwanted hand and finger movement. To minimize tremor, a microsurgeon must have a relaxed state of mind, good body comfort and posture, a well-supported hand, and a stable instrument holding position. The hand should either directly or indirectly rest on an immobile surface, otherwise unwanted movement will occur. Here you can see in this diagram. To accomplish precise finger movement, the ulnar surface of the forearm and wrist should be supported on flat surface and angled at approximately 20 degrees to reduce muscle tremors. During the surgical procedures, the surgeon head should be comfortable upright position, and patient and chair position must be adjusted to the surgeon and the microscope. The forearm should be slightly supine, positioning the knuckles away from the clinician so that the ulnar border of hand, wrist, and elbow are well supported. In these photos, you can see the most comfortable position of the forearm and the elbow. Now comes the hand grips. The commonly used finger grip is the pen grip, which gives greater stability. The instrument is held exactly as the pen would be held with writing, when writing, and the thumb, index, and middle fingers are used as tripod. Any tremor resulting from thumb or index finger is maximum contact with the supported steady middle finger. Accurate exact hand movement with the instrument of correct length and design along the precision hand grip are crucial to good microsurgical results. Now the concept of microsurgery. The microsurgery is based on three important forms the microsurgical tride. It was given by Kim uh, et al. In 2001. According to that, there are three things, that is the illumination, magnification, and the instruments. Now coming to the illumination, in that there is a dental loop and the surgical microscope, the illumination for dental loops and surgical microscope. Dental loop manufacturers offer collateral lighting system or a suitable fixing option to compensate for the decreased illumination. Loops with larger field of view will have better illumination and brighter image than those of narrow field of view. Surgical microscope uses coaxial fiber optic illumination, producing an adjustable, bright, uniformly illuminated, shadow-free circular spot of light that is parallel to the optical viewing axis, which allows the surgeons to view periodontal anatomy that previously could not be seen. Now, the second track, that is the magnification. The magnification, the second component of microsurgical tride, the main aim of which is to improve the visual acuity. Two basic type of magnification system are commonly used, that are the surgical loops and the surgical microscope or the surgical operating microscope. They are basically the mechanism of magnification. There are two mechanisms under which it works. First is the Kaplerian optics. The loops work on this mechanics. Has two lenses where it angled to focus an object. Here you can see focus an object. And second is the Galilean optics, on which the operating microscope works. Have a binocular eyepiece which is joined by offset prism to establish a parallel optical axis and permit stereoscopic vision without any eye strain and convergence. Now there are optical principles of loop on which the loop works, that is the working distance, the working range or the depth of the field, the width of the field and field of view, and the convergence angle. Now coming to the working distance. It is the distance measured from eye and the object in vision and usually ranges from 30 to 45 centimeters. Correct working length never allowed overextension of the neck, chin, or by shoulders. Other is the working range or the depth of the field. It is the range between which the object remain in focus. The depth of the field decreases as the magnification increases. The proper depth of the field will allow the clinician to avoid too much leaning and overextension while practicing. Now, the width of field and the field of view, the angular extent of an object when viewed through loop system, the higher the magnification, the smaller the width of the field is there. The convergence angle, here you can see, it is pivotal angle aligned to ocular lenses such that they point at an identical point, distance and angle. It defines the position of extra ocular muscle that may be important source of fatigue. Now, dental loops. Loops have long been used in dentistry. The magnified image that is formed has stereoscopic property that are created by the use of convergent lens system. They have a fixed magnification that cannot be changed. They are classified as simple loops, compound loops, and the prism loop. About the simple loops, they consist of a pair of single side-by-side meniscus lenses. Each lens has two reflecting surfaces, with one occurring as a light enters the lens and other when it leaves. The magnification can be increased by increasing lens diameter and its thickness. The disadvantages are there. The greatly affected by spherical and chromatic aberration that distorts the image, shape, and color of the object being viewed. Because of their size and weight limitations, they have no practical dental application beyond a magnification range of 1.5x. Now, the second is the compound loop. Uses multi-element lenses with intervening air spaces to gain additional refracting surfaces. Magnification can be increased by increasing the distance between the lenses, thereby avoiding excessive size and weight. It can be commonly mounted on the eyeglasses. Here you can see. Advantages, it is achromatic, and disadvantages, it is poor magnification, working distance, and depth of the field. They are optically insufficient at magnification above 3x. Now the last, that is the prism. Most optically advanced type of long magnification. It contains rooftop prism that lengthen the light path through a series of mirror reflection within the loops. The magnification ranges from 3.5x to 10x. The advantages are better magnification, wider depth of field, longer working distances, larger field of view, and the barrel shape of list group are shorter and can be mounted on eyeglass or a headband. The disadvantage is it is more expensive than the other two loops. Now coming to the surgical operating microscope. This allows stereoscopic vision at a magnification of approximately 4 to 40x with an excellent illumination of the working area. It combines the magnification of loop with the magnification changer and a binocular viewing system. The field of illumination is very close to the viewer's line of vision. Therefore, the surgical field will be illuminated and free of shadow. Now coming to the component of an optical unit, it consists of an eyepiece, binocular tubes, magnification changer, objective lens, and the lighting unit. Here you can see the eyepieces magnifies the intermediate image generated in the binocular tube, and the binocular tubes contain two inverting prisms that rectify the inverted image produced by objective lenses. The magnification changer consists of two Galilean telescopes in the cylinders, and the objective lens forms the image of an object, and the lighting unit is for the illumination of the surgical field. The loops versus surgical microscope. What is the basic difference? In short, we can say loops versus surgical microscope. 1.5 to 10x magnification is there in loop, and 4 to 40x magnification is there in surgical operating microscope. Loop need no additional illumination for magnification of 3x or greater, whereas surgical microscope uses excellent coaxial fiber optic illumination, hence does not need additional light sources. The loop of operator eye comfort is less, as the eyes must converge to view the image, whereas in operating microscope, eye comfort it has a parallel binoculars. Loops initially easy to use, whereas microscope basically training required to use surgical microscope. Loops are less expensive, and whereas operating microscope, they are expensive, and loops cannot provide variable magnification, whereas the surgical microscope has the advantage of providing variable magnification. Now, instruments, that is the microsurgical instruments. The magnification enables dentists to use smaller instrumentation with more precision. The microsurgical instruments have color-coated surface in order to avoid the metallic reflection under the light of microscope. And the working tips are much smaller than those of regular instruments. Their handles are rounded, circular in cross-section, so that fine control rotating movement can be executed. Microsurgical instruments are made of stainless steel and titanium. Titanium, because of its strength, lightedness, and non-magnetic characteristics. The stainless steel are magnetic, and they are slightly heavy, and less strength is there. The instrument should be 10 to 18 centimeter long, and the weight should around 15 to 20 grams in order to avoid arm and muscle fatigue. Here you can see in this photograph, you can see this is a blade which is conventional blade of 15 number blade. When you compare it with the microsurgical blades, when you will compare it with the microsurgical blade, that is the sclerent knife is there. You can compare the size. And now second one is the needle holder. This is the conventional needle holder and the microsurgical needle holder. Now various other instruments which are used in macrosurgery, and that first is the periodontal knives. They are very sharp, excellent for making precision cuts. In that, the gingivectomy knife is there, and the Orban's periodontal knife is there. You can see. Now coming to the ophthalmic knives, compared with standard 15 blades commonly used in periodontics, the smaller size of ophthalmic knife facilitate surgical work. The different types of knives are there, that are the crescent and the many crescent knife, blade breaker knife, spoon knife, lamellar knife, and scleral knife. Crescent and the many crescent knife, here you can see it in the photograph. First is the many crescent and the second one is the crescent knife. It can be used for intracircular procedures, and it is available with one piece handle or as a removable blade. It can be used in connective tissue graft procedures to prepare the recipient site or to obtain the donor graft. The spoon knife, it is beveled on one side that allows the knife to track through the tissue adjacent to the bone. It is frequently used in microsurgical procedures to undermine tissue, enhancing the placement of connective tissue graft. Here you can see it in the diagram, spoon knife. Other is the blade breaker. It has a handle onto which a piece of ophthalmic razor blade is affixed, allow for infinite angulation of the blade. Other is the lamellar blade and the scleral knife. Other ophthalmic blades are there, that is a keratome blade, enlarged blade, side portal, lens tip blade, and MVR blade. Now coming to the other feathered microsurgical kit is there that contain blade and handle. Here you can see the blade and the handle. Feather blade are appropriate for a wide variety of procedures, such as sulcus incisions on thin gingiva. It creates flaps, molar surgery, capillary incision, and much more. You can see the various types of blades as well as the handle, number 7. Now, other comes as the SEM comparison of the incision made with 15 number blade and an ophthalmic microsurgical feathered blade. The red circle in the upper right image shows the area magnified in lower right image. The green circle shows the disruption of only one epithelial cell. Some microsurgical elevators, there are different types of elevators used for precise undermining the release of flap. In that, Pritchard periosteal and periosteal C is there, and you can see other periosteal also. Yeah. Okay. Now the next thing is the microsurgical retractor. Wider and thinner serrated end provide better anchorage on the bone and prevent accidental slipping. In that, KP1, KP2, KP3, and KP4, you can see it here in the photograph. The microsurgical forceps, the micro forceps can make those maneuvers that cannot be performed by hand. The most popularly used micro forceps are 15 centimeter long with 0.2 to 0.3 millimeter tip. In that, here you can see the straight jugular forceps and curved jugular forceps. Microsurgical anatomic tissue pliers and still micro tissue forceps are there. The other microsurgical chisels used for precise bone cutting. Here is the Fred chisel and Rhodes chisels are there. You can see that it is available in microsurgical form. Now the microsurgical curette. Langer curette combined the best features of Gracie shank bend and the universal curette blade available in 4 designs, and it can scale all surfaces. Excellent for use during periodontal surgery and soft tissue degranulation. The numbers are SL 1, 2, 3, 4, 5, 6, and 17 and 18 are there. Now coming to the microsurgical scissor, most commonly used scissors are 9 centimeters, 14 centimeters, and 18 centimeter long. The tip of the scissor blade are of 2 types: straight, used to cut sutures, and curved to dissect vessels and the nerves. Other scissors are the macro Vance tissue scissors and ligature scissors. The microsurgical needle holder. The length of most commonly used micro needle holder are 14 centimeter and 18 centimeter. Usually, a minute tip that is 0.4 millimeter is used for 8-0 and 10-0 sutures. The needle holder with a 1 millimeter tip is used for 5-0 and 6-0 sutures. Here you can see the needle holder. She needle holder is here. Microsurgical needle forceps can easily grab micro sutures, which can be torn with usual surgical suturing concept. In this, you can see Castrovicius suturing forceps and microsurgical con tissue forceps. Now the microsurgical suturing. What is microsurgical suturing? To achieve microsurgical wound closure, a surgeon depends on how the incisions were planned and executed, how the surgery was performed, and the suturing technique. Now coming to the principles of microsurgical suturing, there are 3 important principles of microsurgical suturing. First is the eliminating the dead space. Second is closing with sufficient but appropriate tension, and third is the immobilizing the wound. The microsurgical needles, the most needle used in dental procedures are 3/8 curvatures. A reverse cutting needle of size 16 to 19 centimeter is used most commonly in periodontal surgery. Needle of fine gauge material that are small and designed for maximum needle holding stability are used. Here you can see the reverse cutting needle with precise precision tips are there. The shallow needle track and precise needle point allow extra accurate opposition and closure of flap. Spatula needle, which you can see it here in this diagram, the needle that is 6.6 millimeter in length and curvature of 140 degree, allowing precise apposition, closure, and immobilization of the soft tissue graft. Now the microsurgical sutures. The sutures of choice is monofilament uh, suture material. They are bacteriostatic and non-inflammatory, hold the knot extremely well, and are easily removed. The main important thing is the color of the suture material is important in microsurgery since non-colored material is invisible even under magnification. Here you can see the various size of the suture, that is 80, 70, 60, and 40 vessel size increases. Now there are few points for suturing geometry, macrosurgical suturing geometry, that is needle angle of entry and exit of slightly less than 90 degrees, and the bite size should be approximately 1.5 times the tissue thickness to achieve proper approximation. Equal bite size, that is symmetry on either side of the wound, and needle passage should be perpendicular to the wound. Here you can see the entry of the needle less than 90 degree. Here you can see this suturing also. Symmetry on either side of the wound. The result of geometric perpendicular suturing are uncomplicated wound closure as compared to when suture pass across an incision line at an oblique or an acute angle, resulting in dead space or micro gap with long post-operative healing. The example of geometry of micro suturing, you can see it here in this photograph. The properly done microsurgical suturing, whereas this is an example of conventional surgery suturing later viewed under magnification, under a microscope. Now, application in periodontal therapy. Cleaner incision, closer wound apposition, less reduced hemorrhage at the surgical site, and improve outcomes obtained from the use of microscopic periodontal surgical procedures have resulted in a shift towards periodontal macrosurgery. The reason macrosurgery has gained acceptance among some periodontists is not reduced morbidity, rather the endpoint appearance, which is simply superior to that of conventional surgery. Now, microsurgical root coverage procedure, you can see it here. There is a class 2 in A. You can see the class Miller's class 2 gingival recession is there in a canine. Micro suturing with the help of a connective tissue graft or placed in micro suturing was done, and the result after 1 month, you can see it in here. You can appreciate this. Hello. For microsurgical connective tissue graft, this is another case. You can see the recession is there, and with the help of microsurgical instruments, properly microsurgery and connective tissue graft was placed, and micro suturing was done. Here, and you can see it in the photograph, and you can appreciate after 2 weeks. And there's another one more photograph you can see here in figure 1. You can see the gingival recession as well as abnormal frenum is also there. A recipient bed was prepared in figure 2. Figure 3, connective tissue graft was placed, and then micro suturing was done. And after that, you can see you can appreciate after 2 weeks. Here is another case of multiple incision where coronally advanced flap was done and then micro suturing was done. And you can see the after 2 weeks. There's another recession case. Here the same. You can see the connective tissue graft was placed, suturing was done, and after 2 weeks. Now microsurgical papilla reconstruction. Here you can see between central incisor and lateral incisor, you can see black triangle, uh, which can be then in next you can see the macrosurgical connective tissue graft was placed and then suturing was done, and you can appreciate this after 2 weeks. The macrosurgical periodontal regeneration. The advantage of macrosurgical approach in regenerative therapy relate to improve illumination and magnification of the surgical field that permits proper access to and debridement of intravenously defect with an increased accuracy and minimal trauma. Here in the radiograph, first photograph you can see in radiograph bone loss is there. The surgery was performed by placing a graft in furcation area, grade 2 furcation, and the micro surgical sutures that was given, 60 sutures was given. There is another case which is given Carenza, you can see microsurgical crown lengthening. In this, you can microsurgical crown lengthening procedure alter passive eruption covering teeth crown, and the second photograph is the immediate microsurgical post-operative result and post-operative healing after 3 weeks. Microsurgical implant surgery. Microsurgery has proved its potential in implant surgeries. Different stages of implant treatment ranging from implant placement to implant recovery and peri-implantitis management may be accomplished with more precision under magnification. The periapical, here you can see the periapical radiograph of a typically fractured central incisor, flapless dental implant microsurgery. Under the microscope, a socket appears to be large as a room with its apex and wall clearly visible. The implant was placed and the healing abutment was placed. Now coming to the drawbacks of microsurgery. It is a technique sensitive, so required special equipment and specialist training. It is an expensive setup and high patient cost. It is limited access as magnification system used also pose some difficulties, including restricted area of vision, loss of depth of field as magnification increases, and loss of visual reference point. An experienced team approach is mandates microsurgery, and it is time consuming to develop. Now, lastly, the future perspective. Periodontal microsurgery offers an improvement in predictability, cosmetic result, and patient comfort level over conventional periodontal surgical procedures. However, the end-point appearance of microsurgery and the conventional surgery are simply not comparable because of the remarkable advantages that magnification offers the microsurgery. The microsurgery will shift the focus of periodontal procedures from macro to microfield, thus achieving precise results. Hence, periodontal microsurgery seems to show promising clinical results and appears to be a natural evolution for the specialty of periodontics. Thank you for the patience listening.
Thank you, Dr. Sanjay.
And this is my department. And this is my college career dental college. Thank you.
Thank you, Dr. Sanjay. It was a very nice lecture, and you nailed it to be very true, because you explained that microsurgery is one. It is not. It is something which a periodontist must know, or rather, he or she must practice microsurgery for more precise and decisive outputs or results in perio. Um, I think the questions are not there anymore. Um, uh, I'm really thankful to everybody. There were so many people. Dr. Pradeep Tandon was there from Lakhimpur, and many dignitaries were
may I
there. I
speak?
know, sir, आप काफी देर से कुछ कहना चाह रहे हैं. Pradeep sir, please.
I appreciate very much the effort by Dr. Sanjay, and this brings me closer to my teacher, Dr. Jaya Dikshit. Her father was ophthalmic surgeon, and she used to tell us at that time that for giving more precise work, you should look at how eye surgeons are working, how nicely they are putting their work in the eye. So this all equipment and say greater possibility of doing finer work brings us closer to more precision. And I appreciate Dr. Sanjay for this. Thank you so much.
Thank you. Thank you, sir. Thank you.
Over to Dr. Ben, sir. Sir, please.
Thank you, Dr. Sanjay, and
Thank you, Dr.
we
Vivek.
also had with us Dr. Silva Kumar and other faculty members who joined this program. And Dr. Sanjay, thank you very much. In the cool wave, also you have actually started your presentation on time, and thank you very much. A little bit of delay was there because of electricity failure in our institution. So I guess you all cope up with that. And here I'm sharing the certificate. Dr. Sanjay, this is a certificate of appreciation for you, and we will send the certificate by email to you later on. Thank you very much. Thanks all the participants. Thanks all the audience. Thank you very much.
Thank you, Dr. Vivek. Thank you. Thank you all.